안녕하세요, 박종현 원장입니다.
Greetings, I'm Dr. Park Jong-hyun. Complications that occur in the aesthetic region is not easy to address, so we need to diagnose and place implants considering many different factors. We always try to do our best, but let's talk about how to overcome the complications that occur. If you look at this case, which is a rather embarrassing case, many upper anterior teeth are lost. I placed this implant a bit distally. It should have been placed here. So mesiodistal implant position would affect aesthetics quite a lot. In this case also, regrettably, the implant was placed in the embracer, resulting in aesthetic result. When we place an implant in the incisor area, we need to be careful not to invade the embracer space. The space is too narrow for 4 anterior teeth. The space is narrow and central incisor is to be placed. We need to be very careful during the placement. If an implant is placed just a little bit to this side, it in itself would adversely affect aesthetics quite a big way. So using a digital guide can be of great help. In a limited space, placing 3 implants is quite difficult. 3 teeth were extracted and placing 3 teeth here would make the space too narrow. There is a chance to invade the interdental space. Thus, placing 2 instead of 3 implants would have greater aesthetic result. Instead of the place of central incisor, an implant should be placed in the lateral incisor, and the central incisor should be treated with a pontic. That is much more aesthetic in terms of the treatment outcome. Let's have a look at the lower anterior region. Actually, the embracer problem in the region is much more challenging. Guided surgery was performed to place implants in the positions that I wanted. A problem, I used to place the MS implants. The cut side is positioned horizontally like this, and I wanted to open the embracer a little bit more. Teeth are lost due to periodontal disease. Opening up of this area would make the maintenance easier. But this implant section was too thick, so embracer was not properly formed. Talk about my recent approach. Here at 3 years, it is maintained pretty well. However, if I opened up the embracer space a little bit more, periodontally, I believe the result would have been much more stable in the long term. Now it has evolved. Now it is positioned vertically. Now there's a room for opening up the space for embracer. Positioning the implant sections in this way, in the side way, opens up the space for embracer. So sufficient embracer spaces are provided. Another case, the biggest problem when it comes to implants to be covered by national health insurance. We know one-body implants are ideally designed for lower anterior, but they are not covered by the national health insurance, so we place TS-type implants. Rather than using 2-piece abutments with a separate screw, using 1-piece abutment would be much more favorable for creating embracer spaces, and we don't try to fit the margin. The margin is arbitrarily set. There are many negative comments about the 1-piece abutments, so I don't really use them, but the exception is in the lower anterior region. If you use the 2-piece implant abutments in the region, it is very difficult to create the embracer space like this. Next, incisive canal. According to the literature, the invasion to the incisive canal It's rarely accompanied with paresthesia due to the cross-innervation between the great palatal nerve and nasopalatal nerve. I was not in the right mind when I placed the implant in the incisive canal like this. I was worried about that, so I removed the implant that there were some distance to the residual bones, so the placement was moved like this. It was a good thing that I did that. It is reported that not serious complications occur with the incisive canal invasion, but if it is placed like that, the osseointegration area would be very unfavorable because the implant is in touch with the soft tissue. It is not good to compress the nerve. The patient complained for about a month, weird feeling on the palatal side, maybe due to the damage. However, there was no complaint anymore after 1 month. Incisive canal invasion is not serious, but if it is compressing the nerve like this, the placement site needs to be moved. This case was performed in 2006 with an implant with metal collar. When I was a resident, regrettably, it was placed outside the envelope on the palatal side. If the implant or bone level implant like TS, it would have been a little bit better, but an implant with metal collar was used. So the gingival level was good, but soft tissue follows the bone forms, so the gingival level became worse. As long as patients do not complain about that, there is no problem, but the gingival level is not matching like this, there is a problem. In order to prevent the problem, I prefer to use the TS type implants, the bone level implant, rather than the tissue level implant. TS implant is more appropriate, and it is important to place an implant within the labial envelope. This is a similar case. It was during my residency around 2006. I was not doing implant surgery. Implant surgery was performed by the oral surgery department. I was observing the implant placement and I realized the screw hole was formed too much buccally, so I stopped the surgery. An approximate position of it was marked on the stent using the Durolite pattern resin. Before the secondary surgery, the custom abutment cast was prefabricated, and this was tried in like this. If the healing abutment was connected like this, a gingival level would have been very different. But on the second operation day, prefabricated custom abutment was connected to prevent the gingival level going upward. So final prosthesis was completed. I believe this is a pretty good result. So if an implant is placed too much labially, healing abutment should not be connected immediately. Instead, angled abutment can be connected to reduce the gingival recession. After 9 years, the natural tooth with the root resorption was maintained for quite a long time. The interdental bone was remaining, not much of it was lost. So what I learned from this case is that if the placement is labially performed due to bone condition, if it is inevitable, there's no choice, but if it is too much labially placed, instead of connecting a healing abutment, an angled abutment needs to be used to prevent the gingival recession. A regrettable case, 2 years after restoration, gingival recession and inflammation developed. You can see the residual cement here. I don't know exactly what the cause was, but all I could see was the cement. Prosthesis was removed. It was remade with a tie link abutment. 4 years and 5 months after the first placement, and 2 years and 3 months after the delivery of the prosthesis with a tie-link abutment. I don't like the form of the abutment. If it is formed like this, it would be better for better bone response. It remained rather stably even with the use of the abutment. This abutment has a very good form and a biocompatible abutment, but that is not the whole story. I believe the key reason for the inflammation would be the residual cement. If you look at the form of the abutment, it is not very good. It is pretty wide here, but it is accepted by the human body and is maintained. Another difficulty when it comes to anterior restoration is the black triangle. As reported in the literature, if the distance from the interdental bone to the contact point of adjacent tooth, if it is 5 millimeters, 100% of gap would be filled. If it is 7 millimeters, we would observe the black triangle. After a year, the soft tissue has crept up. We observe such cases quite a lot, especially among young people. Another case, immediate placement after extraction. Many senior patients do not complain about the black triangle like this. If they do not complain, my routine approach is I just leave it like that. If it is left empty, embracer will follow the form of the patient naturally. That would be better. Another case, a young patient, relatively young patient, and there is a black triangle problem. See, the color is quite different too. I tried to erase the stain as much as possible, but it is still shiny. Different from the adjacent teeth, and this part is filled with resin to reduce the black triangle, and the patient was satisfied, so we decided to observe. And the case leaves something to be desired because there's a big difference in the colors, and porcelain itself is too much glazed. So this is the case from the previous lecture. Restoration space is too wide compared to the adjacent teeth. It is congenital situation. Give the choice to the patient. If the adjacent tooth is not to be restored with resin crown, leaving the space like that would not be a bad choice. The patient is used to it from before the tooth loss. Another case, so the tooth was extracted because of a periodontal problem. The space is quite large compared to the adjacent teeth. Implant placement was performed with bone grafting, and in the adjacent tooth, resin restoration was provided. Resin restoration in the adjacent tooth can be helpful to close the gap. The resin filling should be considered from the time of planning implant placement, and it should be determined on which side the resin filling would be provided. This tooth is very wide, and some people prefer it to reduce the space. So aesthetics is not totally dependent on the numbers, but what is important is patient satisfaction. To address the space problem, I let the patient choose options. The process is evaluated using provisional tooth. So this is a concern. There's an existing implant, and the distance between the implants is too close. If it were placed better, the distance could have been wider, but there is adjacent tooth, and there is a limitation where a drill can go in. If the smallest diameter abutment is used, the soft tissue remains here so it can be maintained. So when the distance between the implants are very small, a small diameter abutment should be used to provide continuous soft tissue as much as possible. The space is not good enough for 2 implants, and I decided to place 1 implant. And the cantilever amount would be reduced to the maximum, so distal to the central incisor, an implant was placed. This is the center. Thus, an implant was placed a little bit distally. I tried to reduce the cantilever on both sides. ER-type prosthesis was chosen and the palatally positioned screw hole was made. This is a groove, not a screw hole. The final prosthesis was completed with cantilevers. If the space is too small, if MD space is too narrow, then placing 2 implants, placing 1 would reduce problems. The distance between implants needs to be 3 millimeters. If it is less than that, we need to use a thin, narrow abutment to secure the soft tissue between the implants. And if it is 2 millimeters or 1.5 millimeters, the distance, placing 1 implant can reduce or prevent complications. On angled driver case, even if the placement is in the incisal direction using the angled driver, the prosthesis, the ER type can be fabricated. However, over time, after 2 years, the metal color is revealed. Showing of the metal color can make the anterior case a failure. In that case, some people use connective tissue graft to address the problem. I'm not very good at that, so I removed the prosthesis and made it again. If the prosthesis was a cementation type, removing the prosthesis could have been cumbersome, but with the angled driver, the prosthesis was easily removed and the maintenance would be easy to do. Still stable after 2 more years. Actually, this is a sad case. The metal abutment fabricated in the lab, actually I reduced it a little bit further. The metal here was reduced because it was thicker than I expected. Maybe due to the thin zirconia space metal was showing. After 5 years, functionally there was no problem, but whenever I see the patient, I felt sorry. This part, the color is different. If the inside was coated with gold, the problem would be much less serious and the opaque treatment might have made a difference. Opaque treatment will be explained later. This patient, there are not many residual teeth and the zirconia prosthesis was used. The same prosthesis, but the metal is showing here. So opaque treatment was provided. The final prosthesis was tried in. As the thickness of the prosthesis was thin, the opaque was showing, making it look different from adjacent teeth. In order to address the problem, the abutments themselves should have gold color or tie-link abutments can be used to treat it with zirconia rather than using the metal color. If it is thick enough, the metal or opaque would not be showing, but if it is thin like this, that should be considered. Recently, I use PFM for anterior implants. The PFM restoration, if metal margin is increasing later, it can be very unaesthetic, but the color of abutment is metal, so I don't think a PFM would create a particular problem. The key to prevent complications lies in the implant positions. Implant body top is positioned at 4 to 6 millimeter deep from the marginal gingiva. After osseointegration, a buccal marginal bone should be at least 1.5 millimeters. The key is problems can be addressed if an implant is placed with a screw hole on the palatal side. To ensure buccal marginal bone thickness and the palatal screw hole in the anterior region, implanted body diameters and length should be appropriate. This can lead to lower primary stability as the length and diameters can be reduced, with less stability at the apex. However, I can sacrifice other factors and I want to make sure palatal screw hole is provided. I believe most of the mechanical complications lie in the failure of providing screw retightening rather than the crown implant ratio. To obtain stable connection rather than the crown implant ratio, we need to use authentic abutments. Maintenance of preload of screw can be performed from screw retightening only. Therefore, we should not go aggressive in terms of implant diameters, lengths, and the primary stability, but we need to make sure that screw holes are positioned as palatally as possible. This concludes the 3 lectures for the anterior region. Please come to the offline master course for more details. Thank you.